Good evening, Facebook. Welcome to our Tuesday TIF Talk. I'm Karen Girth, Market Development Manager at Endogastric Solutions. I'm here with my colleague, Wendy Profit, and we have our guest tonight is Dr. Amandir Dhaliwal. Thank you so much for joining us.
Yeah, hi, everyone. I'm Dr. Amandir Dhaliwal. I'm based in Florence, South Carolina with McLeod Regional Medical Center. Background-wise, I'm a gastroenterologist and trained in interventional endoscopy. And so we deal with a lot of GERD-related interventional procedures and specifically TIF. But I'm glad, and thank you, Wendy, and thank you, Karen, for getting me in here because I know as per the US, I was just very curious in reading that one of the most healthcare burden, around $9 billion a year, is just acid reflux. So it's a big topic, and I think it's something we all need to work together to see how we can help the folks in here.
Well, thank you so much. You kind of did your intro for me, so I appreciate that. I will add that Dr. Dhaliwal currently practices at McLeod Digestive Health Center in Florence, South Carolina. So he's joining us all the way from Florence, South Carolina, not Italy. So let's just kind of jump right into it. Dr. Dhaliwal, can you just kind of tell our viewers, what is GERD and some of the atypical and, typical symptoms that they might have?
Yeah, so, the GERD, the first thing is, learning the full form. Some people always comes in, they don't know, somebody gives them, said, I am here for a fancy problem. It's called GERD. So what is GERD? GERD is a gastroesophageal. What is gastro? Gastro is stomach. Esophageal is your food pipe. And reflux is the acid which is produced in the stomach. And disease is because it's causing symptoms and the patients are in problem. So that's what is called GERD as a full form. So what is GERD? Normally, every human being, whenever you have food or whenever we are doing normal activity, we burp. Sometimes we have those gastric contents and everything. So that's pretty normal that, you can have those things. When do they become a problem? They become a problem when they start causing symptoms. The symptoms could be acid reflux, heartburn, regurgitation. These are more of the atypical, or in layman terms, what we say is indigestion. That means I have indigestion. And now when you go forward, some people do not have these classical symptoms. They have something called atypical symptoms. And one of the most common atypical symptoms is chest pain. But whenever this happens, I always tell my patients, the first and the most important thing is, have you talked to your cardiologist? Is there something we need to rule out? Because I know the most non-cardiac, that means non-heart related cause of chest pain is GERD or acid reflux. So always motivate them, make sure you have seen your cardiologist. And once that workup is negative, then you come to the gastroenterologist or seek help from them and see how we can help you. Now, the other, which is very difficult to treat, are the extralaryngeal symptoms like hoarseness, chronic cough. And honestly, these are the most difficult symptoms you'll be able to treat versus not treat. Sometimes you do your best, but still you're not able to because you're still not sure, are these coming from the esophagus or there is something pulmonary thing causing it? Is there an asthma involved in it? We don't know. So always I set up an expectation when a patient comes to me, specifically for the atypical symptoms, which is the LPRs, or which is the extralaryngeal symptoms, or the hoarseness, or the chronic cough, that these are the something we will try to do the workup, and we'll talk more about what those workups are. And if this is something which I think is related to the GI, we'll work on it. But if it is not, I'm very honest and upfront and tell them that this is something I will not be able to help you with. Because I think it's very important to set an expectation for the patient to right from the day one. Because if you say that you're going to treat and patient is already suffering and they come and you have done all the $1 million workup and then you tell you cannot help them, I think you're not telling it you're not being dishonest, but you did not set up an expectation to begin with. So the patient went through the whole thing thinking that he's going to be cured.
Yeah, I love that you set realistic expectations. How do your patients, or when they come in, how have they attempted to manage their GERD? Have any lifestyle or food modifications that they, are doing to minimize it?
No, that's a great question. By the time we are seeing, most of the patients have gone to their primary care physicians, have gone to CVS, Walmart pharmacies, done all over the counter Tums, the basic home remedies to see what can help them. Some people even have gone to Google and Facebook group chats and see if there is any GERD diet. They're already trying to making some modifications. But most of the patients you're seeing are those patients who have done all those and still suffering with the problem of the acid reflux. So to answer your question, yes, I think a lot of people have tried a very basic stuff, whichever to their knowledge they can do it to help themselves by the time they see me.
Perfect. And then, they've tried a lot of these modifications. Can you kind of talk to the audience about, what unmanaged GERD can lead to, why it's important to see a medical professional if you've been suffering for a while?
Definitely. So whenever the patient, first of all, comes to me, I make sure that, is the patient obese? What are the risk factors for his to be acid reflux? Are we talking about smoking? Are we talking about drinking? And these are all what we are talking about, the lifestyle things, right? So the next thing is obesity. Do you have increased waist to hip ratio? What's going on that what we can fix in these patients is, do you eat more cheesy, fatty, spicy foods, more coffee, like, you have a stressful job and you drink like 9-10 cups of coffee a day, what's going on? How can we help? So I think learning the basic history is very important for any patient, because no matter what we think about, anxiety and stress and all other things also play a very big role in acid reflux. And that's why they have a mind of its own, and it's truly have its mind of its own. So we have to see what's going on. So after you have talked about them, you want to make sure that, you talk about exercise, losing weight, you're talking about avoiding any cheesy, fatty foods or heavy dinners or meals towards the night. Do not go and lay in the bed right away when you eat the food, give a gap of a couple of hours. Put at least 2 big pillows, make an angle of 30. As I said, exercise, eating healthy, change your diet, cut down on coffee and, smoking, drinking, etc. And when they come in, I talk to them is the patients, first of all, even before you put them on a medication, they have read about the medication. And there is a lot of misinformation regarding the medications, which is the proton pump inhibitors, or in normal terms, it could be omeprazole, pantoprazole, esomeprazole, lansoprazole. So patient says, I have read this can cause dementia, Alzheimer's, and all those things. So, a lot of studies have debunked most of these things which have been said. So these medications, risk versus benefits outweighs the risk. And the biggest risk of untreated GERD is esophageal cancer. Before even you go to esophageal cancer, there's something called change in the lining of your food pipe, which can be leading to Barrett's, like, how you call Mr. Barrett. So it's like Barrett's esophagus. Untreated Barrett's esophagus over the period of time, even if you don't have any cancerous changes, has still 0.03% chance of leading to esophageal cancer. This is the most dreaded complication which we are worried about. But apart from that, even before going there, people are miserable. They can't, like most of my patients, and we'll talk more. Most of my patients who come to me cannot sleep in their beds. They are not sleeping with their spouses. They're sleeping somewhere on the recliners outside, because if they go and lay flat on the bed, their life is miserable. They're almost gagging and choking. By the next day, they are again miserable because they did not have a good night's sleep. They are not fresh at work. The anxiety and stress is adding up to their life, and that's causing a big decreased quality of life. So, they are not able to enjoy their food, which they used to enjoy before. And I think a lot of people, food is a big thing. Like, taking away the biggest food out of your meals creates a big problem for the patients. They said, why I'm living if I can't even enjoy my food anymore? So these are very important things to be kept in mind about the uncontrolled GERD,
Yeah, I think a lot of times we forget that the quality of life and that people are really miserable that have severe GERD. I want to pass it on over to Wendy. I know she has a couple questions from our audience before we keep going about diagnosis and things like that for GERD. So
Thanks
Wendy?
so much, Karen. Dr. Dhaliwal, I'm really excited that you brought up what I think this is a huge reason why folks tune into these broadcasts is they want to know A, what is causing this, B, how is this impacting me in relation to how it impacts others? Am I, a more mild case? Am I more severe? As folks are doing their research and trying to figure out what the next step should be. So I really appreciate you talking about that. You touched on something that I'm starting to hear more and more from folks as we are out in the communities and talking with more physicians is how this impacts relationships, right? You talked about a spouse not being able to sleep in the same bed with them, not being able to enjoy mealtime with them, et cetera. And I'm really glad that you touched on that because I think this is something that goes unspoken about many times, how it impacts not just the person suffering from GERD, but those who love them as well. So I do appreciate you pointing that out. Also want to know a little bit about what this acid really does. What is it capable of doing? Obviously, GERD is essentially acid being where it's not supposed to be, right? So what does the profile of that acid look like? What is the strength of it? What does it lead to above and beyond just discomfort in the patient? Can you talk a little bit about that?
No, definitely. So, basically acidic is pH. When we are always talking is a pH. pH is where you say that, this is acidic or alkaline. 4 is a pretty strong. And that's how we basically even do the measurements when we are quantifying the acid reflux using our Bravo or 24-hour pH testing catheters. So anything less than 4, when you are basically, that's an acid which is going in a place it should not be going. One of the things I said was it erodes the lining of your food pipe or esophagus. When it erodes means it causes changes. It can make, because what is going to happen is if your esophagus is going to be prone to acid reflux, it has to become like stomach so as to absorb the reflux, to absorb how much acidic component it is. So how it's going to become like a stomach, it's going to start developing the lining of a stomach. And that is what we call Barrett's esophagus. And that Barrett's esophagus is already a precancerous lesion for the esophageal cancer, and that's what you do. Apart from that, not only before that, it can cause esophagitis. What is esophagitis? Is inflammation, ulceration. It can make people difficulty swallowing. So whenever people eat food, they say my food it gets stuck in the back of my chest. I then have to regurgitate or vomit, or sometimes when I drink a lot of fluid, it goes through what causes a lot of pain. And where is that pain coming from? Pain is coming from that esophagitis or that inflammation or that ulcerated area where the food is passing through. Some people will say and get admitted to the hospital. They said, last night I was eating food gets stuck in the back of my chest. I put a finger in the back of my throat because I was feeling as I'm gagging and choking. And when I regurgitated, vomited, I saw some blood. They get admitted to the hospital. And when you do the endoscopy and you see an endoscopy is again putting a camera down your throat into your esophagus, shining the light in there and seeing what's going on in there, you see these people have bad inflammation, ulceration. And from the ulceration, they're so friable that they're oozing. Sometimes there's a small tear because of the retching. So all these things itself cause a lot of trauma to the patients, which is called loss of or missed work, not enjoying the food, always a worrisome, avoiding social gatherings that, if this happens, what I'm going to be doing or not. And then eventually when this esophagus if left alone for more time and we don't do anything, these ulcerations will try to heal, because body has a mechanism to heal anything with a secondary intention. And what's going to happen is you're going to develop a narrowing or strictures, or which is called obstruction. And for example, this is your lumen, it's going to become very small. And when it's small, becomes small, you're going to have an impaction of the food, and you will have to end up in the ER because of that.
Very good. Thank you. I also want to thank everybody who is chiming in on our comments. If you have any questions, please go ahead and ask them for Dr. Dhaliwal. Want to say hi to our viewers from Connecticut to Philadelphia to both North and South Carolina. I'm seeing just in the feed so far. If I've missed you, I'm sorry. But just thanks again so much for being with us. One last question, then we'll turn it back over to you, Karen, to talk about just diagnostic testing, how to figure out what's really going on. Is to your point on acid and what it can do to damage the lining of the esophagus. A lot of folks will ask, well, how about if I drink water? Will that help?
Yes. So drinking water itself, because water doesn't have any healing protective action. So drinking water when you are eating a lot of food will help glide that food, go in, depending on what stage of esophagitis or ulceration you are, how much narrowing it has caused. But if it has caused, to the point that it has scarred and caused a lot of narrowing, water itself will also cause more damage, because the food is stuck and now you're adding water to it. So you're going to vomit everything out and you are at a risk for aspiration. So if my suggestions to all the folk, or recommendation to the folks, is that if you are facing any of these things on daily basis, do not wait for one night when you want to get stuck with that food bolus or that food in there in your chest, and it's 1 a.m. and you're miserable and you want to end up in the ER. I want you to go today or tomorrow, call your primary care physician and get an appointment and get to see a gastroenterologist before you end up in this kind of situation, because you are not only at risk of putting a tear or a hole in the esophagus, because the esophagus, when there's the food bolus, what does it do? It does contract. So if the food is stuck in there, it's going to go crazy and it's going to start contracting a lot. When it does, it gets tired. And what's going to happen? It's going to put a tear or a hole in the esophagus. You can aspirate from the vomiting. So these are all dreaded complications. Food, and again, I said the water will help in the initial stages to glide it down, but towards the later parts, it's not going to help you much.
I appreciate that. Thank you so much. All right, Karen, back to you.
All right, well, thank you. Well, that's a good segue that we kind of discussed, PPI use and managing your GERD. Can you kind of talk a little bit about, the tests that are used to diagnose GERD?
So the first thing is to go and, as per the guidelines, is put the patients, do you have any risk factors? Risk factors could be, you have any anemia, you have any weight loss, you have any B symptoms, you're having any bleeding, all those things put you at a risk, and you want to go ahead and jump directly, or your age is more than 55. You want to go ahead and go directly with an EGD. And EGD is, again, putting a camera into your esophagus when you're sleeping with the anesthesia to go and check your esophagus. You see whether there is a damage, there is an esophagitis, there is an inflammation, there is an ulcer, or there is nothing. And as I said, you will be surprised. Sometimes there are a lot of many spectrums of GERD. There is something called non-esophageal reflux disease. That means you're not having any damage to the esophagus, but you still have symptoms. You can have hypersensitive esophagus. That means you don't have any reflux, or you and me could have the same reflux, but your esophagus is more sensitive than mine. Or you don't have anything. It's just the nerves making you perceive that. So there's a lot of things in there. So the EGD is the first step, which helps us to find whether you have a damage or not. And if you have a damage, what kind of damage you have, whether you have narrowing, whether you need dilatation, whether we need to do biopsies, whether we need to bring you back for the EGD, whether you have something called Helicobacter pylori in your stomach, we do the biopsies up there. Celiac disease itself can make you prone. So we always, sometimes in the younger folks, we try to get the small bowel biopsies as well. So once we do the EGD and we have found out that, whether we have damage versus not. Now, if I go in, I don't see any damage, and your esophagus looks fine, but patient says that medication is not working for me. The next step would be, we can do a couple of things. We can bring in for 24-hour pH testing. That's a catheter we put through your nose, leave in your esophagus, and it's tightly wrapped around here so that you can go and continuously do whatever you're doing in your daily life. You don't have to modify any diet. Do whatever you do exactly the same you do when you have the catheter in there. You will have a monitor, and they will tell you to put the symptoms in there, and you press the buttons whenever you're having symptoms in there. You bring us the monitor back, and then we basically go over and see whether you have acid reflux or you don't have acid reflux, or you have non-acid reflux, or you have hypersensitive esophagus, or it's nerves making you more susceptible, but actually you don't, physiologically, you don't have acid reflux. Number two we can do is called Bravo study. Bravo is like, some people will say, I cannot tolerate that catheter. That's too much. That's going to go through my nose. I have a pretty strong gag. I'm going to vomit it out. Doc, I cannot do it. So what we do is, when we are doing the EGD at the same time, I tell my patient, if I don't see any damage in your esophagus, because that's what we want to make sure, it has to be done off medications. So you have to stop your medications for at least 48 to 72 hours. We'll go in, and then we'll place a small capsule, that's called a Bravo, which is placed in the esophagus or 5 to 6 centimeters above your GE junction to record how much acid reflux you are producing. Now, the good thing with this is you can do day 1, day 2, day 3, day 4. So, and even day 5, you can extend it up to 96 hours. And some people try to do is day 1, day 2 without the medication, then day 3, day 4, they introduce the medications like the PPIs to see, does the acid go down? So that's the good part of Bravo, we can do it. Now, if I go in and I see you already have an esophagitis, but it has 4 grades, Los Angeles A, B, C, and D. If you have C and D, that tells me that you have a pretty good amount of acid reflux. I don't need any further testing. Now, what we have to talk about is how we're going to treat it.
And that's perfect. That was my next question. So, how, once you've done all the tests, what options are available? There's surgical options, there are non-surgical options, and if you could kind of, go over some of those for us.
So perfect. So, the first step is, again, like as I said, even in younger people who do not have risk factors, you don't even do the EGD. You start them with the PPIs. You can start with 40 once a day. And, this is one very important point I want to make here is that this has to be taken empty stomach. 30 to 60 minutes before you wake up in the morning or before your breakfast, or if you're on it twice a day before your breakfast and dinner. A lot of folks take it with their food, and sometimes the action goes down. It doesn't help as much as it could have done as an empty stomach. Or some people say, when I eat food, I'm miserable towards the middle of night. When I'm going to bed, then I take it. So, it might help, but it's not going to help as much as it's going to be helping you out before. Now, again, 12-hour action, it should be good. So again, when you have given like 8-week challenge doesn't work, you increase it twice a day to the point it becomes refractory. That's when we start talking about what's our next step. The other thing which I did not talk about is, when we do the EGD, the other landmark which I'm also looking at is called hiatal hernia. That do you have a hernia? And what is hernia? People say, oh, I never feel it. Do I have a knot in there? No. This is some kind of a hernia. It's called a sliding, or it could be paraesophageal. That means what happened is, normally your diaphragm is creating a barrier between your esophagus and your stomach. When it becomes a little loose, or your gastroesophageal or the lower esophageal sphincter becomes, I'll say the diaphragm becomes a little loose, or the angle of His in the diaphragm becomes loose, that's when you see the herniation of your stomach into your chest. Now, it could be as small as 1 centimeter, it could be 2 centimeters. Why this is important for us, because, and we will talk more about it, because what we can see is that with the newer technology, if it is more than 2 centimeters or less than 2 centimeters, and if it's less than 2 centimeters, can we do something about it without going in more invasive surgery? If it is more than 2 centimeters, what are our options in there? So that's very important, and then going forward is talking about, first and the foremost important is, if you have esophagitis, is to heal the esophagitis before even think of the surgery. because we want to make sure that if you have esophagitis, if you have Barrett's esophagus, if you have Barrett's with dysplasia, which means any precancerous lesion occurring from the Barrett's mucosa, we want to make sure we are treating those things before we jump onto a surgery. So that means that you are completely eradicating it, or achieving a remission in that point, because you don't want to do a surgery in any inflammation and cause more trouble than actually not. Once that thing is taken care of, the next step is, as Karen mentioned, surgical and non-surgical methods. Non-surgical is, again, lifestyle modifications. You are doing your treatment, whereas most of these patients by this time are already heading towards some kind of surgical intervention. Back in time, we had more options where if you had a hiatal hernia more than 2 centimeters, you go to a surgeon, he will basically fix your hernia. Basically, what he's trying to do is he's restoring your diaphragm valve or the angle of his. He's basically recreating the dynamics so that you, and pulling down your stomach where it should be and creating or elongating the length of your esophagus so as to fix that hernia. And that is done when you have more than 2 centimeters. And then back in time, and I just think that a lot of surgeons still do a lot of wrap, and we have Toupet, we have Nissen, we have 360-degree wrap, we have 270-degree wraps, and they used to do it. Now, what they do is when they are fixing the hernia, they are fixing from the outside. When they're creating the wrap, they're creating the wrap from outside to the inside. So they're not visualizing it when they're creating that wrap for the folks. So that's where I think, and I will stop here and let Karen ask, if there are any more questions, and we'll keep on talking more about it.
Well, thank you. And that really leads us into now, the TIF procedure and how does it work? And, I'm just going to follow that up too with what draws your patients to TIF.
So, when I came in and in the interventional world, TIF, a TIF is, again, what is TIF? It is a transoral. Transoral means going through your mouth, incisionless. That means when you wake up, you should not see any incision on your stomach or something. And that's the beauty of it, right? People love, and especially my female patients, they're very conscious about, any marks or surgical marks about it. And, some of the males, I don't want to discriminate here, but, a lot of my female patients will say, do we have a surgical mark in there or not? Fundoplication. And what is fundoplication? Is creating a wrap. And what is creating a wrap is basically restoring your lower esophageal sphincter, because that's causing all the acid reflux. Now, if your hiatal hernia is less than 2 centimeters, we don't need you to go through a surgery with a surgeon. That means you don't need a laparoscopic approach to fix it. What we do is we directly go with the transoral incisionless fundoplication. We go with a EGD scope. The device is loaded on the top of it. We do a dilatation empiric because it's almost 60 French. Am I right, Karen? It's 60 French, right? Yeah, so it's 60 French. So it's almost close to 20 millimeters. You divide it by 3 when it's going down here. So we want to make sure it has enough of space. Patient is intubated. Patient is on ventilator, which means he's not breathing on his own. And the reason why he's not breathing on his own and he's taking the help of the ventilator is because we want the diaphragm to relax. And when the diaphragm relaxes, that actually tells us what's the length of the hernia is. Because sometimes we are thinking it's less than 2 centimeters, but when the diaphragm relaxes, it's actually more than 2 centimeters in there. So when we go in with the scope up in there, it's basically creating that valve. And how do we create that valve? Basically, we elongate the esophageal length, create the omega-shaped valve, restore the dynamics of the angle of His, and basically what we are doing is restores the high pressure zone, which is towards the lower esophageal sphincter, to prevent the acid reflux coming in. And how do we do it is basically putting up the fasteners. We have approximately one cartridge has 20 fasteners, and we try to go it more on the anterior approach. And the anterior approach is the lesser curvature of the stomach. And this basically, again, we'll talk more about how does it help, how is it different from the different techniques, and how the patients are tolerating it better than the other stuff. Now, once we have done this, This is called straight transoral incisionless fundoplication. Now, if you have hernia, which is more than 2 centimeters, I always call my surgeons, that, hey, I'm sending you a patient. Please have a office visit with them, talk to them and see what they do. They love to do a esophagogram with the barium tablet. They want to see how big the hernia is. Sometimes it undermines it because it could be sliding hernia, and by the time you're doing the barium swallow, it could be slow. But I tell them, I promise you that this hernia is bigger than what you actually see on the barium swallow. So what they do is that me and my surgeon, we plan a OR date for the patient. The first thing is my surgeon's going to go in. He's going to basically fix the hernia. Once he fixes the hernia, my team goes in, and that's how we do the same, what we're going to do with a straight TIF. But the only difference is that the surgeon has fixed the hernia, not me, because of meters.
Thank you for that explanation. It looks like we have a lot of questions from our audience, so I'm going to send it back over to Wendy to ask you a few of those.
Thanks, Karen. Well, we've got Miami and Houston on as well. Hi, everybody. Thanks for tuning in. Want to ask Ryan's question, which is, if I have Barrett's esophagus, can I still get a TIF? I think you touched on that a little bit earlier. Yes. Maybe talk a little more about at what point that is a possibility.
So if you just have Barrett's esophagus, sometimes the treatment is TIF, and it also depends how much hiatal hernia you have, because the problem is you are taking the medication, but you have an open, you have no barrier, your sphincter is wide open, and you are having all the acid reflux coming into the esophagus, which is causing all the Barrett's esophagus changes in there. So the treatment would be that, depending on the hiatal hernia, if it's less than 2 centimeter, can be whether we need a surgical or directly go into a straight TIF. So you can get it done. Now, if you have a dysplasia means if you have any precancerous or low grade or high grade, the first thing, and which I've touched base before, is to eradicate that thing. We don't want that we go in and we do a TIF, and when we are doing that TIF and we are reducing that thing, that gets buried somewhere during creating that wrap, and then eventually that grows into a cancer. So you have to make sure that has been eradicated completely, and it's called CIM or CEID, complete eradication of dysplasia. Once you have done complete eradication of dysplasia, we can still consider doing in CIM, and then go forward and then plan for your surgery.
Excellent, thank you. Lauren asked about tests that you have to get to be a candidate for the TIF procedure. I think you touched on those. Can you talk about what type of results yield a good TIF candidate?
So the first important thing, which I did not touch, was the manometry. The most important thing is we have to make sure that your esophagus contractions are fine. Because if your esophagus contractions are not fine, it's like I'm going to create another roadblock for you by creating that wrap in there. So the first and the foremost is your motility, or the coordination between your esophageal muscles, should be normal. That's called manometry. So those are very good candidates. Now, sometimes, this is very important, we have ineffective esophageal motility. What is ineffective means? That doesn't mean that you have discoordination between the muscles. You have so much of severe acid reflux that can cause discoordination. So sometimes I will do a barium esophagogram with the barium tablet to make sure, is this because of the acid reflux, or this patient has something which I'm missing, because I don't want to go and create a wrap for my patient and create more problems, because what we are trying to do is help you guys in here. So that barium tablet, if it goes fine and it shows a lot of acid reflux, that's a good candidate for a TIF procedure. Number two, for pH and Bravo, your Demeester score should be more than 14. You should have failed PPIs, or even like, if you not even failed, you're on the maximum dose, then you want to cut down on it because you don't want to do it on a long-term basis, is also good candidates for it. Again, for straight TIF, hiatal hernia less than 2 centimeter. Hiatal hernia greater than 2 centimeter is more with the surgical colleagues doing a seat. It's called concomitant. And again, obesity, BMIs are very important. For straight TIFs, less than 35 is very important. For C TIFs, my surgeons have a cutoff of 40.
Okay, very good. Thank you. So Corey is asking about the ability to get a TIF if there is a large hiatal hernia present. Is there kind of is there a cutoff? What threshold do you look at there?
So we had a recent patient who had 11 centimeter of hernia. Almost half of the stomach was sitting in the chest, and first my colleague went in and reduced and fixed the hernia, and then I went and created the wrap for the patient. And I just saw a patient 2 weeks ago that was, I think, 2 weeks out for the surgery. She's doing fantastic.
Great, thank you. Last, and then Karen, I'll head over to you. Chuck is asking, and this is a great question. We often glide past this one, but so many people want to know, when is the right time to go in and see someone? At what point should I go and see somebody about my acid reflux?
So if you are thinking about it and you are seeing this show, that means you should call tomorrow your primary care physician to send a referral to a gastroenterologist. Because if it's in your mind, you are taking medications, it's affecting, or it's making you think in your normal daily routine life and it's affecting you, do not wait. And as I said, specifically, this is for the folks who are having daily symptoms, who are having food getting stuck in the back. Do not wait for that one night or Christmas Eve when you have a big portion and the food is stuck and you are miserable at 1 a.m.
Thank you very much. All right, Karen, back over to you.
Thank you, Wendy. Now that we've kind of talked about the TIF procedure, can you just kind of talk about the recovery, pre and post-op diet? We get a lot of questions about the diet. Could you kind of touch on those for a bit?
No, that's great. So as I said, if I do a straight TIF, my patient is intubated and it's extubated right away after the procedure. And my normal recovery time is 4 hours. We just observe them. Earlier, we used to admit them overnight, but more and more we have got comfortable with it, that we just send them home after 4 hours. And, we send them on Maalox because of, if there is any burping, that helps with that. Lidocaine swish and swallow, because obviously there is some swelling, edema, inflammation. We do send them with pain medications for like 3 or 5 days to just tide over it, because obviously you have put the fasteners in, you have created a valve, and it's slightly painful. But apart from that, my patients do very well. I've never got a call, and I give them my phone number. So I give them my own cell number so that they are not lost in anywhere in the call center or something, because nobody else knows what I've done. I know what I've done. So I make sure that they have my cell phone, but I can promise you that I have not received a single phone call from a patient in the middle of night that I am miserable. I just see them at the scheduled clinic and they say, I said, you never called me. I said, I never needed to. So that's how it is. Diet is very important. When I bring my patients to the clinic to talk about TIF, I take out the TIF booklet. And, that's why Karen and Wendy, I have Ryan send me a big package of those booklets. So I open the booklet and say, and I have it here, and I just want to show you guys. So this is exactly what it looks like. So this is exactly how I show my patient. I said, you will have to start with clear liquids for a couple of weeks, then slowly go to full liquids, then slowly go to soft texture. By week 6, you should be ready to have something medium texture food or something which you were eating before. And the reason why this is very important, because what we are trying to play around is accommodation. The stomach is accommodating. And I always compare it with a little child who throws tantrums, who is very indisciplined. And nobody has ever tried to discipline that child. And what happened is, suddenly goes to a school and the teacher says, John, you cannot do this. And what does John do? John's going to throw all the tantrums there. He's going to be trying to whine. He's going to cry. And same is your stomach. Stomach was doing whatever it wanted to do. It wanted to throw in acid reflux. When it wanted, it did that. Now, suddenly you have created a valve. You have created a very nice TIF procedure. You have a nice valve looking. The fasteners are there. And suddenly it says, why the acid is not going? So it's going to start gurgling, contracting, and that's where the diet helps. That means the clear liquids and full liquids in initial period of time decreases the load on the stomach, especially the fundus part, for accommodation. So this is very important. And I tell my patients, do this procedure if you can follow the diet. Because if you will not, I promise you will call me in the middle of night, or you will call wherever you are that I have the worst pain of my life because the stomach is accommodating and you did not help it. You just ate more and made it miserable. So diet plays a big role. And my patients on average are losing 10 to 15 pounds during this diet plan, and they're very happy with it. Because what's happening is they always wanted to lose weight and everything, and that gave them a very good reason. And, you know, as I said, one of the risk factors for a lot of folks who are asking that is obesity. So this thing not even helps with you helping with the accommodation, but also lose weight. And this also decreases your risk factors, not even from the Barrett's or otherwise, but also the cardiovascular diseases. So I think TIF is a wonderful procedure. I tell my patients we do 2-in-1: lose weight and we fix your acid reflux.
I love that, and I love that you set those realistic expectations for the diet, because it can be hard to stick to. I guess as we're wrapping up, what are some of the things that your patients are saying or that their loved ones have said since they've gotten the TIF procedure? Anything they can do now that they couldn't do before?
Yeah, I think they're sleeping with their spouses more. They were sleeping on recliners before. They are not smelling bad because they used to have a lot of acid reflux when they woke up in the morning. The quality of life is better. They're enjoying their food. As I said, they have lost the weight. They're better in shape as much as they could be. A lot of them, actually, in my experience, again, Karen and Wendy can tell more, almost 80, even 85% of the people are off acid reflux as early as 5 to 6 weeks. So I was very surprised when they say, "Doc, I'm not even taking acid reflux. I don't feel I have acid reflux."
That's wonderful. And then, as we're wrapping up, any parting thoughts for our viewers? Anything that you would say to someone who's considering the TIF procedure?
Yeah, I think, there's always a fear in mind that what I'm going to happen, is it invasive? It's a pretty safe procedure, specifically if you're doing a straight TIF. The adverse events are anywhere from 0.37% to 3.2%. So what I'm talking is if you go for a colonoscopy, or if you go for an endoscopy, upper endoscopy, that's exactly where the risk factors are. So it's nothing more than doing an EGD. Exactly what I put to my patients. And if you're doing for C-TIF, that means if your hernia is more than 2 centimeters and you're going with the surgery, and then your gastroenterologist or intervention endoscopist is fixing for you, is 1.4%. So it's even lower than the regular EGD, what we are doing in there. So go and discuss with the people who are doing this, search. I'm pretty sure Karen and Wendy have the links for you guys to search for the nearest physician or the interventional gastroenterologist who can go and help you with the
Okay, that's it. You're going to host next week. You have done our jobs for us tonight. This is fantastic. As a matter of fact, we were going to remind folks about our physician locator and the patient education app on their mobile devices that we have available. As they search GERD Help, they'll be able to find a link to that in our feed. So thank you very much for teeing that one up for us. Before we close out, though, I do want to ask, can you talk a little bit about physical recovery? We talked about diet. Now, should somebody expect to go ahead and roll out of the bed and go on a walk their first day? What do you think is optimal as far as physical activity goes as they recover?
So a lot of my TIFs I'm doing on Wednesdays because people want to take Friday, Saturday, Sunday, Monday off, and then go back to work on Mondays. A lot of my patients, I've talked to them, they're walking around. There's no problem in getting out of the bed, walking around. You're not sick. You're not a patient. You have actually overcome that disease by going through this procedure. So do not feel that you have some kind of a physical disability now that you have underwent a surgery or a C-TIF or a straight TIF. So you can go around, do a normal work. What I tell my patients is do not do any cowboy things like, okay, you're going in the kitchen and your wife is lifting something and say, honey, don't worry, I'm going to lift it. Or wife says, hey, honey, can you move this up? just try to, I know you want to impress her, but try to focus and see you got that surgery done. Limit yourself and say, I'm sorry, I cannot do it. So limit your any weightlifting, heavy lifting, any strenuous exercises. Like you can walk. That should not be an issue. You can do your daily household works, whatever you're doing. That should not be a problem. But I will strictly avoid anything heavy, whether it's gym, whether it's household, whether it's running or any strenuous activity.
Thank you very much. All righty. Karen, you want to close out?
I will. And thank you so much for joining us tonight, Dr. Dhaliwal. And as he had said previously and kind of teed it up, if you are looking for a physician in your area, you can go to gerdhelp.com. If you're in the Florence, South Carolina area, go to our physician finder and you can find Dr. Dhaliwal. And as Wendy mentioned as well, if you need more information, please download our GERD Help app. It's available on the App Store for both iPhone and Android. Thank you all again for joining us tonight. Thank you, Wendy. Thank you, Dr. Dhaliwal. And we will see you next week. Happy holidays.
Yeah.
Pleasure.
Happy holidays, folks.
Thank
you for having me here. Really. Yeah, thank you.